Welcome to the Shockwave Therapy Podcast. My name is James Woolwich, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you.
Today we are talking to Drew Klein, president of FocusWaveClinic.com, which is a specialist shockwave clinic in Ottawa in Canada. He works alongside a vascular surgeon in treating erectile dysfunction, other men's health issues and chronic pain. Really excited to talk through his ideas on the use of shockwave in these conditions, particularly as he, as opposed to lots of other guests on this podcast, just uses shockwave and it's a specialist clinic just for that. He's got an excellent website, which is worth looking at if you're interested in using shockwave for erectile dysfunction, Peyronies disease, and so forth. It's really nicely laid out and very clear to people looking at the website what they can deliver. So really looking forward to understand how he's developed his protocols and indeed the business side of delivering shockwave in this arena.
So thanks for joining me, Drew. And I'm really happy that you're on here because I get some nice emails off of North Americans, as I have to group you together with the US of A, saying that they listen to my podcast, and that's nice. And the other reason it struck me as being opportunistic is the subject of erectile dysfunction and men's health just keeps coming up. I've done a few podcasts recently on this, and when you got in contact and I saw the makeup of your website, it struck me as it was a lovely website. I mean, and your backdrop is nice, obviously, as I just said. But there's over here in Europe, there is a tendency to see shockwave as an adjunct. So you'll see a physio clinic or a normal andrology clinic or an endocrine clinic in London where they use shockwave as a part of what they do. But I quite like the bravery what you've done. You've really gone out and set your stall and said this is a pretty much everything focused around the shockwave and what it can bring to bear on erectile dysfunction and chronic pain. So that's why I was looking forward to this evening, because I've never seen that. That's pretty unusual. So can you just give us a background on how you set up and what your position is in the company and where you're at?
Sure. So I'm the president clinical director of FocusWave Clinic, and we did start off the clinic with the intention of focusing strictly on shockwave therapy, focused shockwave therapy for men's sexual health. We do at some point see some branching off potentially happening, but for now we have remained focused on this very specific modality and treating these very specific conditions. So, I'm not a doctor. I went to school to be a doctor. I was a biology major at the University of Waterloo, and I realized in my fourth year that I couldn't do it. Wasn't toiling away in a lab or being a doctor or being a surgeon was not for me. It's just not something I could do.
Yeah.
So I did 10 years in high finance, living in Los Angeles. I did 10 years in high tech here in Ottawa. And so when the stupid COVID hit, I realized that this was as good an impetus as any for a career change. It seems like my attention span is only about 10 years. So I met Hugo, who's our MD here at FocusWave, through a friend of a friend. He's a vascular surgeon from Ecuador, a Canadian international medical graduate. And in my opinion, there was nobody better to discuss sexual health conditions, specifically erectile dysfunction, or shockwave therapy, which promotes, the neovascularization of the treatment area. Nobody better to discuss this type of treatment with than with a vascular surgeon. So I was very attracted to the idea of working with Hugo. And because we know ED is mostly vasculogenic in nature. So Hugo's, kindly, gentle, refined old gentleman, 67-year-old doctors, how they should be. He smells good too. That's a plus. So he described to me his experience with shockwave therapy. He was using radial, acoustic wave shockwaves, on patients and having limited success. So, but he described the focused or the linear shockwave therapy devices, which are a much more powerful version of shockwave therapy, and how this device can successfully treat all these different sexual conditions, ED, PD, chronic pelvic pain syndrome, and more importantly, treating them with no pain, no side effects, no pills, and no surgery. And so I was blown away by, I had been in high tech for the last 10 years. I was blown away by the technology and what it had the potential to do.
Hmm.
So we started up this clinic, got it all set up, and we launched October 2020 in the midst of a pandemic, in the midst of a lockdown here in Ontario, Canada. And we've been off and running ever since.
Well, that's a great story. So when you met him separate to the idea of shockwave, it was a chance happening, or did you purposefully go out to meet someone that was already in the field and say, you know, do you want to set this up and we should use focused or whatever? Or
it was through a friend of a friend, somebody who we all went to the same gym together, actually. At
right,
the time.
okay.
So yeah, I was a friend of a friend, and I, always interested in my background in science always has kept me interested in this field. And then, once this stupid COVID struck, I figured this was my way back into the healthcare biomedical field,
And so did you between you two, you did some research and then discovered that, I mean, because we have this over here, is that, and I think over there, without mentioning names, the major marketplace is acoustic or radial wave for ED in North America. Over here, it actually is via the research, it is focus based. But we see that there are more and more clinics trying the radial approach. And, I get questions about this all the time. And the vast majority of the research, by a significant margin, is with focus. So you must have discovered that yourself, had you, over there? Because you're up against, I'd rather not name names, but there's a major company that are absolutely huge in North America, and they promote radial, albeit the research is not there. So,
right.
I mean, the technology is a lot more expensive, but you must have done the research and reading and said, this is the way we want to go.
Yeah, I mean, we, with, Hugo's experience in treating people with ED using a radial device, realizing it's a painful procedure, realizing that there are side effects and numbing creams and downtime, and then realizing that there was a much more advanced device that you could use that was also approved by the national regulator here, and that also was covered in all of those peer-reviewed studies. I mean, as you know, most of the peer-reviewed studies that show success for using shockwave therapy for these sexual health conditions are using focused devices. Yep. So we found a lot of these clinics, and as you know, radial and acoustic devices they're very useful. They're very helpful in certain, for certain orthopedic pain conditions. They have their use in the medical field, but when it comes to treating, the very sensitive penis and crura area and treating ED and PD and CPPS, you need something that can achieve the depths required. So what I always compare, because we get a lot of people who come, clinics, in Ottawa and around the area, and also, what you're talking about is Gaines wave. I don't know if that's a pejorative or something, but using radial as a tool for treating ED. I mean, apparently they have some success, but from my understanding is it's painful. It requires numbing creams for many men, and it just can't achieve the depths required that you need to treat ED and PD to clear scar tissue and break up plaques and to create the neovascularization. I always compare it to when I'm talking to a potential patient, I say, you can go to a clinic that offers radial or acoustic wave or whatever wave they want to say, but that's like a bicycle compared to a fighter jet when you compare it to a focus wave device or a focus shockwave device. The focus shockwave device is supremely more powerful. It's electromagnetic. It's not pneumatic and noisy and painful. It's the next generation, the most advanced technology possible in this modality.
And can I ask what you use? Do you use a Storz device?
Yeah, we use the Storz SD1.
Okay, but you don't have the radial with it, or does that come with the radial?
No, you can buy the radial. We haven't. We've looked at it for because you could also use it to treat we use the Focused as well to treat some chronic pain conditions. It's not.
Yes, I saw that on the website. Yeah.
Yeah, it's not a majority of our business because there's, as I'm sure it is in the UK and many places, very, very competitive in terms of the physio and the chiro markets.
Yeah.
And while we do seek referrals from those people for this highly advanced treatment, it's not something that we really advertise or push hard.
Okay. So I guess you have the advantage of the doctor working with you in this country, in the UK. We can't prescribe or anything else. We can only suggest, and we try to liaise as closely as we can with the patient's doctor on this subject. But do you use a combined approach? Does he also prescribe any of the medications, Viagra and so forth, alongside the treatment? Or do people tend to see you because they don't want to take the treatment, the medications, and they see this as an option on the side?
Yeah, we're a private clinic, so we do not. And Hugo is an international medical graduate, which means that he's not a Canadian College of Physicians a doctor. He's well trained in shockwave, but we aren't able to prescribe these pills, the PDE5 inhibitors. What we usually see is if it works for the patient, that's great. As you know, for some people, the PDE5s don't work anymore, or they don't work very well, or they just want to avoid taking pills altogether. So the patient certainly has that option, and it's usually up to the discretion between him and our clinician as to what's the best way going forward as far as adjunct treatments, additional things, whether going to see a naturopath or going to see a dietitian, which, as you know, those are all very important things to look at as well when you're considering taking your sexual health back.
Okay. And do you, because this is still relatively new, relatively novel, although it's been probably around for several years, there's still some debate as to, how many sessions, the space between sessions, and so on and so forth. From your experience, what sort of protocol do you use? And, so for example, do you do blocks of 5 sessions? Do you assess them first to see whether they're severe using, various questionnaires to sort of suss whether they're going to need 10 sessions? How does your process work when you see those patients first?
So I'm always very interested in the practice of medicine, because it really is a practice. There is nothing that is truly set in stone here. We need to get better and improve at the technique that we provide. So the literature, in most cases, as you know, in the peer-reviewed studies, they tend to do 6 treatments as a standard course, twice a week for 3 weeks, seems to be the standard. And we futzed around on a few different strategies there, sometimes offering 8 treatments, sometimes offering 4 treatments in a row, or 3 treatments in a row, twice a week, or 3 times a week, twice a week. We found that the best success we've seen so far in your average patient has been doing 6 treatments twice a week for 3 consecutive weeks, trying to do it at the same time for the patient so they feel like it's part of their routine schedule for the next 3 weeks. And that's for erectile dysfunction, for mild to moderate erectile dysfunction. For severe cases, we generally are suggesting 12, 6 followed by a 2-week break, and then another 6. But it does depend on the patient and the severity of their condition. I mean, as you know, some guys come in and you
have a 6-week break between the 2 6s.
No, 2-week break. 2-week break.
2-week break. And why do you have that?
We've also discovered over the last 7 months that we've been treating patients that during the healing period that follows the 6 treatments, that there's gains that can be seen in terms of shim score performance. So we give everybody a shim score when they first come in, when they complete the treatment, at 45 days and at 90 days as well. And we've noticed that during this healing period, where the body is continuing the process of angiogenesis and neovascularization continues, and the blood flow tends to improve and the performance tends to improve during this healing period. So it is a I guess I don't want to say destructive. It is a very serious medical process that does take time to heal. Your body doesn't need that time. So we give them a 2-week break in between those 2 6 treatment courses.
Okay. And can you just explain to everyone what a shim score is?
So sexual health inventory in men is just a basic five question questionnaire
Okay,
that determines your the severity of your erectile dysfunction. So
fine.
it's ranked on based on 1 being the lowest score and 25 being the highest score. You're basically a porn star, and or how you were when most people when they were 18, and 1 being somebody who is not having sex, avoiding sex, can't perform sex.
Okay, fine. All right. Um, so I'm assuming you're getting good results with this. And what when patients come to see you and they say, because they do, it's going to be reasonably expensive, and what are your success rates and so forth. What sort of things do you say to patients? Depending, let's say you're mild to moderate, what sort of chances of success are you saying to patients from your experience in the clinic?
So again, we always kind of revert back to the peer-reviewed studies, which show about a 70% success rate for patients lasting anywhere from 18 months to 5 years. That's what the realistic numbers
Yeah.
show. And so, what I try to iterate to our patients is, first and foremost, it doesn't work for 100% of people. I mean, that's a given. Nothing does.
Mm.
I believe we're seeing in our clinic even better numbers than the 70%, closer to 80, 85%.
Okay.
And there's a reason for that. I think it's because we don't have to be as rigid as the studies tend to be. They
Mm.
tend to be very very
Well, they
structured,
have to
and
be. Yeah.
to be a good study, it would have to be so.
Yeah.
And we don't have to be so we increase the number of treatments. In some cases, we offer a few additional treatments if the patient's not quite seeing what they wanted to see. We target different areas in the body, different areas on the penis and the crura area. We increase the frequency of the shocks. We can increase the number of shocks. We can increase the energy level of the shocks. And again, that's the beauty of these focus devices, that you really
Mm.
have this flexibility. So it does depend on the patient's condition, but we try to make sure that our patients understand that this is not a magic bullet. There is no panacea. Some of our patients have been dealing with sexual health conditions for years and years. And as men, first of all, we don't like to seek medical treatment. It's not in our nature to admit that we have a problem. And so that's why there's the gender health paradox, and that's always an interesting discussion. But for the most part, men want to see results immediately. I know I do, and it's not necessarily a realistic idea of how this actually is supposed to progress. So, but the success rate that we're seeing right now is unbelievable. It frustrates me to see patients who don't see success, but what we try to do is we try to push them after 12 treatments. Generally speaking, if it's not working for you, it's not going to work. That's what we believe. And so we don't want our patients to just go away and say, well, that was a waste of 6 weeks, and that was a waste of several $1,000s. We try to encourage them and push them to make other lifestyle changes and make other improvements in their life, that be it diet, exercise, sleep, intellectual stimulation, whatever it might be. We try to push them into these other avenues, which they should be doing in concert with this treatment as well.
And I don't profess to know anything about the general healthcare system in Canada, but what's the general acceptance level amongst mainstream medicine in your country for this type of treatment? Is it still extremely new and no one knows about it, and doctors are being very cynical about it? Or are you starting to get a sense that there's now, oh yes, no, that's an alternative. If you don't want to take medication, there's a clinic down the road that does this. I mean, we're still struggling with that slowness over here, I have to say.
I think it's very anecdotal. I mean, many doctors, even one of my best friends is a urologist, and they had an old shockwave therapy device in their clinic, and they pretty much gave up on it. I don't think they used it right, or they didn't really spend much time on it, so they kind of just dismissed it as not really being an effective tool. And when I've showed him the results, he's totally blown away. So I think, doctors know what they know, and they 100% of them know to prescribe PDE5 inhibitors. That's just easy. Write a script and here you go. This will, treat the symptom. But for the most part, doctors are mainstream doctors aren't very interested in focusing on treating the cause. And in this case, with focused shockwave therapy, we're going after the root cause of the problem rather than just treating the symptom. And I mean, again, like I said, I'm not a doctor. I have tremendous respect for anybody who's gone through the process of becoming a doctor. But and we try our very, very best to put this technology in front of all the doctors in our city and wherever we plan to expand to show them that this is a non-invasive, safe, effective procedure for treating sexual health conditions.
Yeah, good for you. I mean, we certainly have, as I said at the start of this, I think we're seeing this being much more prevalent in terms of the noise around shockwave. And because I have a podcast and I teach it along with some colleagues, you know, we're getting it asked of us much more now, because it used to be, you know, I've been involved in it 8 years and it was all about Achilles tendons and plantar fasciitis, and now it's much more the conversation. What does it do with ED? Yeah. And indeed with some doctor friends of mine, you know, they are aware of it as well. So it's, I think
our medical systems, like in Canada and the US, have a lot of similarities. There's a very large public component to our healthcare. It's free, like it is in with the NHS in the UK, and so private healthcare like this, because we're private. We're a private clinic and we don't accept any forms of insurance or anything like that. So people have to come out.
Does insurance get involved with this treatment at all? They're not there with that?
No, the OHIP, which is our Ontario, which is our healthcare here in Ontario, in the province of Ontario, they do not cover it, and extended benefits from third-party insurance companies also do not cover this.
Sure.
So it's a straight out-of-pocket situation. Did you find that during this? I mean, you've been in this business longer than I have. Did you find that during the COVID you saw a significant decline in the number of patients looking to come? Because, you know, we're dealing oftentimes with people who aren't, you know, at 100% peak health. So some of them might be a little bit scared to venture out or to do things. Did you find a decline in business, or was it flat, or did it rise?
Initially a huge decline for the first 4 or 5 months, but we actually, most of our clinics in the UK shut down for three months ish. Although there was the legal nature of that was dubious, but I think we all felt like we needed to do our part, so we all shut. And then when we started up in 2020, we were running about 50 to 60%, because I think there was a lot of confidence was very low and people didn't want to come out and come into clinics and so forth. But since the start of 2021, we're back to normal pretty much, albeit we have certain conditions that mean that we can't see as many patients. But you know, we're back. We're okay. I'm not moaning. You know, there are plenty of people worse off than us. I still have my business, and it's okay.
Yeah. And do you guys have to? I mean, are there special regulations in terms of how the Storts is the SD1 is classed in the UK versus?
No, in the UK, as osteopaths or physiotherapists, we're allowed to use focused or radial shockwave equally. It literally is, can you afford it? And the training's a bit more specialized, because I'm involved in some of that on behalf of Storts in particular. In Germany and a few European countries, there is a separation off between who is allowed radial and who is allowed focused, between doctors and physios, osteopaths, and so forth. There is a separation there, but not in the UK. We're lucky in that regard. So I have a focused device, I have a radial device, and I use both equally and both in combination. For most of my patients is musculoskeletal, but my physiotherapist, alongside myself, he treats ED and Peyronies, which is the second thing I was going to ask you about, your Peyronies, because that's still a bit of a topic of conversation between me and my colleagues that teach this, because we don't see as many Peyronies disease as we see erectile dysfunction, because there's less of it. And there's been a few cases anecdotally between us where it's flared symptoms up, caused more pain, and we're still a little unsure. There's nowhere near as much evidence and research for it as there is for ED. So what's your experience been? Have you seen some patients for this yet? And what does Hugo say about this?
So PD is obviously maybe a fifth of this. The market is about the fifth of the size, because they say it's only affects about 10% of the men of the male population. PD, Peyronie's disease, being curvature of the penis. So what's interesting about it is that the big thing that shockwave therapy does, as you know, is the neovascularization, the promotion of new blood vessel formation from the existing vasculature, which is very important in the process for erectile dysfunction. But the second and most important thing that shockwaves do is the clearing of scar tissue and plaque, and that's often characterized in Peyronie's disease as having some scar tissue or plaque, either from an injury or from some event that happened that causes your penis to curve. So the success rates we've seen in treating PD for certain symptoms is amazing. We've had great results for plaque reduction, for pain reduction, for improving erectile function, and for sexual satisfaction. The results on penile curvature improvement are somewhat mixed, and
we're finding that
we make sure. Yeah, we make sure that our patients understand that. But there are studies that show using the SD1 that do show a statistically significant reduction in curvature, and we've seen it in our clinic, and our patients have reported it. So in our experience, improving curvature is about a 50-50 bet at this point. I think is somewhat safe to say in this early going point for us. But we also noticed that a lot of patients who come in with PD have ED as well. So we do a combination treatment, a PD ED treatment, and we start all of our patients in a PD treatment course of five treatments once a week for 5 consecutive weeks, followed by a 2-week break, and then we do a 6 treatment course for ED. So we try to first clear out the scar tissue and the plaque, and then we do an ED treatment that follows.
That's interesting, and it sounds very sensible. We don't do that over here. We just do as a mix, but that's going to give me some thinking time, because that makes a whole.
I think it has to do with when you treat both at the same time, your session becomes twice as long. I mean, you need to do 3,000 to 4,000 shocks for each treatment. So you start to look at a 45-minute treatment rather than the 22.5-minute treatment that we're accustomed to.
Yeah. And I think that, with actually some of the flares that have taken place anecdotally, it would make sense not to overdo it in one session, rather than what you've suggested, to spread it with the gap between. Actually, is really good. I'm going to think about that.
It's all practice. It is.
It's novel, it's new, it's exciting, but we're still finding our way. But this is where hopefully conversations like this help everyone, because you're doing it, we're doing it, and we're finding still at the moment what is the best balance to do with that condition, because you say so many of the patients we see are overlapped between Peyronie's and ED, and now I know more about that condition. I'm not surprised. If I had that to live with, I'm sure I would have ED as well, for all sorts of reasons, psychological as well. So yeah, that's interesting. So, but when you do say to the patients when they're coming, so you're fixing their expectations, are you, on reducing pain and increasing performance rather than curvature, which might be almost a lucky after effect, that 50-50 you're talking about?
Yeah, I mean, we certainly try to improve it, and again, it's one of those things where you're not going to come in and do 1 or 2 treatments and say, oh, well, look, it's working, it's fixed. It's a longer term process. There are additional adjuncts that you can use. A lot of guys have been recommended traction devices for PD, which from my understanding, is quite painful. Also some
do you suggest any pump work alongside that with ED?
No, we haven't ventured into that side of the treatment protocol. We've been, again, as you mentioned at the beginning, just super focused on providing this one specific treatment. So but it's a tough one, because the alternative is to go for needles, injections, which also don't have 100% chance for working either. And now you're causing, significant distress and to your penis. And there's not many people I talk to who say, yeah, I would definitely do injections and needles. That most of them are trying to avoid sticking themselves.
Yeah. Although actually, the prevalence of the P shot, as it's called, seems to be growing, but that's a one-off hit. And I hope the PRP is thought to, generate some new vasculature as well and create a healing response. But
Mhm,
I think
mhm.
I think I always say to patients, no matter what the condition they're coming with, why wouldn't you want to try something non-invasive before you try something invasive? I mean, I know what I
Especially
would.
now with COVID and the risk of infection, and you're
Mm,
doing things like that. I mean, to me it's a no-brainer. I mean, I
yeah,
don't
yeah,
like going to the dentist because I find that painful.
yeah, yeah,
So, if I'm dealing with my sexual health and I'm struggling with erections and struggling with my confidence and all of those things come in, you want to go and you want to work with a clinic that's going to provide you with a pharmacological treatment protocol that doesn't hurt, that allows you to leave the clinic and go have sex with your partner immediately. I mean,
yeah,
that's
yeah.
what's so cool about this
Mm,
treatment, is that, you know I have such great stories from our patients. I have unbelievable anecdotes, and they are anecdotes, they are. But when you have an 80-year-old patient who hasn't had an erection in 8 years, and after one treatment he comes in and he says to you, Drew, I had a nocturnal emission last night. And I mean, that's enough for me to say, okay, I made the right decision
yeah,
to
yeah,
this is working for this guy, and it couldn't make me happier to see these success
yeah, yeah,
story.
yeah. Well, look, I think I'm gonna call it a wrap there, because I think that's a nice point to stop talking about nocturnal emissions. What a lovely way of saying it. And I'm going to go away and think about your 5 and 6 combination for Peyronies ED combination. That's nice. I'm going to I'll stick that on my group for the people that I teach with on that this evening. So thanks for stimulating my brain. So in that regard, thanks for coming on. It's been super duper. So hopefully we'll get more listeners in North America listening to the podcast.
Absolutely, and thanks for having me, and certainly look to share more information in the future, and
Yeah.
hope to help more men.
You can only get better by sharing this stuff, right? So thanks, Drew.
Absolutely.
I'm going to say goodbye. I'll
Cheers.
send you an email later. Cheers. Bye.
Hey, cheers. Bye-bye.